Good morning. Thank you everyone for being here. I am Councilmember Lori Ann Sales, the new chair of the Health and Human Services Committee. I want to welcome my colleagues. Councilmember Dawn Lutke is joining us virtually. Councilmember Andrew Friedson is on his way in, and I believe we will also be joined by Councilmember Mink. We have 2 items on the agenda today. I want to also welcome our staff, everyone watching on Channel 16, County Cable, Montgomery, and the live stream on the council website or our council YouTube channel. Today we have 2 significant items. First, we will review the supplemental appropriation for the Affordable Living Quarters project, which will create 18 permanent supportive housing units funded entirely by federal dollars. Second, we will receive the Office of Legislative Oversight's report on racial disparities in maternal and infant health outcomes, a report I requested during my first year on this council in 2022. Without further ado, I'm going to turn things over to Nicole to get started.
All right, good morning. Thank you, Councilmember Sales, and thank you to our partners at the Department of General Services and Department of Health and Human Services for joining us in today's session. As the chair noted, today the committee will be reviewing proposed supplemental appropriation to the fiscal year 26 capital budget and amendment to the fiscal year 25 to 30 capital improvements program for the Department of Health and Human Services Affordable Living Quarters project in the amount of $7,221,940. The county executive transmitted this request on January 15, 2026, and the council held a public hearing with no testimony provided on February 10, 2026. As you noted, the source of funds is federal aid. On April 8, 2021, the U.S. Department of Housing and Urban Development announced the allocation of approximately $5 billion in American Rescue Plan Act funds through the Home Investment Partnership Program, or HOME-ARP. The HOME-ARP funds must support individuals who are homeless, at risk of homelessness, high need, impacted by domestic violence, or veterans and their families. And specifically, the funds can be utilized for the production or preservation of affordable housing, tenant-based rental assistance, supportive services, or the purchase and development of a non-congregate shelter. Montgomery County's Department of Housing and Community Affairs applied for and was awarded the $7.3 million grant. And according to the HOME-ARP allocation plan for the county, the grant would be used to provide these extremely affordable efficiency-style housing units to individuals experiencing homelessness who have regular income, but who are earning at or below 30% of the area median income. The final scope was determined through in-field expert consultation, such as our Department of Health and Human Services and other community partners, public input, and a needs assessment/gaps analysis. The plan also noted that, of course, our Department of General Services, or DGS, will oversee the procurement and completion of design and construction services, while the county's Department of Health and Human Services will procure a property management company to oversee the open facility. The county has until September 2030 to expend these federal grant funds. So a little bit of history on the project. The council first approved the Affordable Living Quarters project in the fiscal year 23 to 28 CIP, and the funding was originally appropriated to support facility planning and site selection research. And the project description form had stated that the total awarded amount would be reflected once a site was selected. However, due to market affordability constraints, the county was unable to determine a final site, and the project status converted to pending closeout. As a result, in fiscal year 25, the county executive recommended and the council approved a reallocation of $150,000 of this federal funding towards a new non-congregate shelter project. The funding was to be utilized to develop a program of requirements for this facility non-congregate shelter to support those who experience acute challenges in congregate shelters. However, in fiscal year 26, the county was able to finalize a site for the Affordable Living Quarters project, which is 600 East Scooty Drive, Rockville, Maryland, 20850. And this supplemental appropriation and amendment requests that full award amount for the planning, design, supervision, and construction costs of the originally proposed Affordable Living Quarters project. The chart at the bottom of page 2 shows you the full 6-year period of how the DGS and Department of Health and Human Services plans to expend these funds from fiscal year 26 through fiscal year 29. With original planning starting in fiscal year 26 and design and construction expected to start in fiscal year 27, with completion expected to finalize by the end of fiscal year 29. As noted, the Affordable Living Quarters site will host 18 deeply affordable furnished and private units for 1 or 2 person households. And the picture on the top of page 3 shows you an aerial view of what that would look like. And the picture at the top of page 4 shows you the conceptual test fit plan for what those units will look like inside of the facility. The executive branch notes that the rental rate will be set at $2,380, which is HUD's fair market rental studio apartment rate for the 20850 zip code. However, individuals will only be required to pay 30% of their income towards that rate, and if they do not have income, have no expectation of a rent income. The site is county owned and has hosted several departments, such as the Department of Environmental Protection or the county's Fire Rescue Service. And the building that will be utilized for the 18 units is an existing on-site and unused building. And this site was selected due to availability and cost considerations, as other potential sites were not feasible due to the acquisition cost. In addition to the units, DHHS will procure a local nonprofit partner to manage and staff this facility. The vendor will provide 24/7 on-site staff, building maintenance, and case management services to tenants. Tenants will be determined through the county's coordinated entry system, referral system, where individuals have a multi-access point streamlined process for individuals and families seeking homeless services. And a standardized assessment tool will be utilized to determine the level of need for housing. The vendor will provide case management for each tenant, which includes annual financial health and wellness and service planning, coordinated physical and mental health care, entitlement benefit application assistance, and house and lease requirement maintenance for the tenants. Council staff did want to note the following. The first is that on January 15th, the county executive transmitted his recommended fiscal year 27 to 32 CIP. So of course, this amendment affects the recommended affordable living quarters project that's included in the fiscal year 27 to 32 CIP. Specifically, that project for fiscal year 27 to 32 had noted operating budget impact costs, so we just wanted to note that here as well, where they expect starting fiscal year 29 about $430,000 in operating budget impacts. This cost was projected based on the personal living quarters model at the county's Progress Place facility, and that includes staffing for a program director, case manager, program support manager, and residential staff, as well as operational costs for building and equipment maintenance and supplies, leases for machines such as copiers and laundry machines, staff recruitment and training, and client assistance. In addition, it will impact the non-congregate shelter project, as this was created originally as an alternative to the Affordable Living Quarters project when the county was unable to determine a final site. While $150,000 was allocated to this project in fiscal year 25 for a customary program of requirements for the new non-congregate shelter space, it was never developed, so this funding will return for the Affordable Living Quarters project in whole. And finally, the Office of Racial Equity and Social Justice does find that the supplemental appropriation is likely to advance racial equity and social justice in the county, as it will produce affordable living units. And according to the county's 2025 point-in-time survey, over 84% of individual adults counted identified as people of color. And council staff recommends approval of the county executive's recommendation. And as shown in the back of the staff report, DGS does have a few visual images to provide of the site if the committee so wishes to view that as well. Thank you so much.
Right. Thank you, Ms. Rodriguez Hernandez. Now we will turn it over to the county executive staff. If you want to share, do you want us to upload the slides? Okay, thank you.
Okay, so thank you so much for considering this appropriation. It's very important for our goal of reducing and ending homelessness in Montgomery County. As you all know and have participated in the point-in-time count recently, that we have a significant number of individuals who are experiencing homelessness in our county. Last year's count, we found that we had 1,510 individuals, many of whom are chronically homeless, as well as very vulnerable. And this housing project is specifically designed for those individuals. And you may be familiar with both the Interfaith Works residences as well as Cordell Place and Seneca Heights. These are similarly designed facilities that are specifically for people with documented disabilities. So this project is very much needed. In a recent gaps analysis, we found that we need an additional 478 units of permanent supportive housing to meet the needs in our county. This project will move towards reducing that gap, and we also anticipate, as you know, losing some of our funding from HUD for our permanent supportive housing program. So these units are really urgently needed, and we have the funding for it already, and we need to also spend it so that we can utilize it and not be at risk of it being taken from us. So I just urge the council to approve the appropriation, and I just appreciate all of your support of this work. And with that, I'll pass it to my colleagues in DGS.
Good morning, Greg Austin, Department of General Services. We can run through the slides if you'd like to take a look at the site. And, so this is also in the packet. I think it starts at Circle 13, but as Nicole mentioned, 600 East Goody Drive is the site. You can go to the next one there. This is an aerial of the site. The building that we're going to be focused on is Building A, which is the brown rooftop in the aerial. There is a building next door which houses colleagues at the Department of Fire and Rescue Services, as well as Department of Environmental Protection, staff offices, and other associated uses. Those buildings won't be involved in this particular project. That's a separate building next door and unimpacted. And so we'll focus on this building. Previously, some years ago, this was constructed and used as a men's shelter in partnership with Montgomery County Coalition for the Homeless. They moved out of the facility pre-COVID, and ultimately the men's shelter was moved to Neville Street. And so that was kind of the musical chairs that was played some years ago, and then during COVID. Following the opening of Neville Street, we then focused with HHS on opening the women's shelter addition down on Crabs Branch, and also other locations in the shuffling and recalibration of services. So this facility, up until recently, was operating with a SAMU contractor as a welcome center for Montgomery County. That use has ceased, and so the building became available. Throughout that entire scenario, DGS and HHS were hunting high and low for a location to use this federal funding. We looked at hotels, we looked at ground-up development and adaptive reuse of closed office buildings and retail sites, all of which were really just cost prohibitive in terms of acquisition and then the retrofits. So this building arrived at the right time, and as Christine mentioned, very similar in nature to the operation that we have currently at Seneca Heights, which is a former motel. And you can see from the building footprint, it's one story, slab on grade, and all of the green here in this exhibit will be the new units once we get done with the interior fit out. So there's 18 units total. A handful of those will be fully ADA. There's community space, community kitchen, lockers for residents, storage lockers for residents, and other amenities. And that's, I think that's the extent of it. Be happy to answer any questions.
All right. Well, thank you again for putting this packet together. Thank you to our county executive staff, and definitely glad that we are here to use federal funds to provide access to more housing to house our unhoused population. I know 18 units may sound like a small number, but this means more residents who are unhoused will have keys to their own homes, a roof over their head, a bed to sleep in, and a place to call home. It's transformative and it is important. I recently participated in the point in time count, which tells us about homelessness in this county, which has increased by over 30% since last year. And as was mentioned, 56% of the homeless adults counted were Black in a county that's 18% Black. That disparity is not coincidental. It's a result of systemic issues that have not served everyone equally. The federal money was awarded in 2021, so it will not impact counties' general funds. It is intended for residents who cannot make it to congregate shelters, those with acute needs who deserve dignity and stability. So it goes without saying that while I support this initiative, I want to ensure that we are building something truly sustainable that meets our residents' immediate and long-term needs. And so I do have a few questions before I open this up to my colleagues. You've already shared that it took 4 years to reach this stage, 5 years almost. Construction is expected to start in FY29 with a federal deadline of September 2030. I saw in the packet but couldn't click on the information about why the previous congregate shelter project was canceled.
So that was the non-congregate shelter that was created in fiscal year 25 when a site was unable to be determined for the Affordable Living Quarters project. That is now no longer needed as the federal funding will be utilized for these 18 units in the Affordable Living Quarters project.
Okay, and so what is the contingency plan if we encounter construction delays?
And I will also note construction is expected to start in fiscal year 27 and be completed by fiscal year 29.
Okay.
Yeah, we have a solicitation out right now for a design firm to begin design, and so pending approval of this supplemental, we'll get that contract underway, and design will commence immediately. We don't expect design to take the typical year that it does for other facilities because it's an existing facility, and those who are in depth at residential will be able to get through the design fairly quickly. And so, as Nicole mentioned, we'll be getting construction in less than a year is the anticipated timeline. So we will know very quickly if we run into any obstacles through the design process, but we know because this is a county-owned facility and we are intimately familiar with the building already, we have very few concerns about moving forward and being able to retrofit this building for the 18 units. So feeling very confident there, but of course we always have plans if things don't work out. But we mentioned Seneca Heights earlier, and it's worth noting that we did include Seneca Heights maintenance, specifically a roof replacement, in the HUD application, so that if there is money, resources left over from this grant that we don't spend here at the ALQs, we will direct those funds to Seneca Heights for a roof replacement, which it desperately needs, and that will happen with the same timeline as the ALQs.
Very good. And so as this conversion is taking place, what is the process for keeping the committee and council informed of the timeline for completion and making sure we're staying on our targeted timeline?
So we'd be happy to update the committee at any point. The next natural check-in for us would be post-design and pre-construction.
Okay.
And at that point, when we're bidding out the project, we have a very good sense of the timeline and the contractor's delivery schedule. So that presumably would be the next opportunity, and we can get you a firm schedule on when we anticipate design completion follow-up.
Sounds good. Look forward to learning more about the groundbreaking. And my last question, what's the timeline for identifying the nonprofit property management company, and how can we ensure these landlords are going to be responsible stewards with this new resource? Are we using an existing partner, or are we open to exploring new partners?
Thank you for your question. So I would say probably a year out from completion, and certainly going along with the county's budget process, we would ensure that the funding to run the program went through the budget process so that we can solicit for a partner who would be open to running the program, who would be experienced, and we have a number of partners who are very experienced at running this type of program. We certainly are open to other organizations who would like to apply. So it would be a bidding process, just like what we have done for the Interfaith Works residences, which was also put out for bid before it opened. And that way they would be able to start running the program once the ribbon cutting occurs. That's how the schedule went for the Progress Place PLQs, or the Interfaith Works residences. So I anticipate and plan for us to have a similar timeline that goes parallel with the construction of the building.
All right, thank you. Councilmember Friedson, and then Councilmember Lutke.
Well, thank you. First of all, appreciate it. It's always good to leverage federal resources. I'm glad that we actually have federal resources. That is, unfortunately, these funds and these programs are, essentially being canceled and being defunded with regularity, which is alarming. But fortunately, this is one that was already approved and one that we can move forward with now. And I'm glad you raised Cordell Place, near and dear to my heart. It's walking distance to me. And actually, my dad worked together with our synagogue and essentially adopted Cordell Place. And so we regularly volunteer there and meet with the residents and provide food. And it's become a synagogue and also a personal family tradition. So, appreciate that. And you can see in those interactions the impact that facilities like this have on people's lives. And so I just, wanted to note that and express how much I appreciate it. I did want to talk a little bit and just better understand what we have done and what the plans are moving forward on any of the health concerns. This is a facility that was vacated based on health concerns previously. That was a fairly high profile and frankly somewhat alarming situation. Ultimately, the Nebel shelter was a response to that issue. Was not a planned dynamic, and ultimately with hard work by your departments and a lot of support from the council and the community, we moved forward with that in relative short order. It was kind of a similar dynamic where we took an existing space and were able to, rough it out and renovate it, fairly quickly in compared to construction projects, particularly government construction projects, which we, notwithstanding the expertise of DGS and Mr. Assant, who does a great job, not always our forte, but just wanted to understand, what's the plan for that? How are we addressing that? What have we done, and what do we plan to do moving forward to make sure that those concerns are raised?
Sure. Great question. Again, Greg Assant, Department of General Services. You're referring to, and I don't remember the dates or the year actually, but it was some years ago, there was a vibration issue on site caused by some of the equipment that DEP operated in their operation of the adjacent Goody landfill. It's my understanding that that equipment has been decommissioned. It was the flare for the methane flare there, and that equipment has been decommissioned since then. In addition, DGS, for its part, not only made modifications to this building at that time in an effort to mitigate those vibration concerns before the equipment was decommissioned, but also have since, and we could share this certainly, provided noise and vibration studies for a period of, I believe, 12 to 18 months following the vacating of that facility to validate that there's no concerns, no health concerns. And so we have all that information available upon request. Certainly the operator, it's a small world, and so the operators are familiar with those events of years past, and we would provide that. HHS, of course, has that already. But no concerns regarding the previous issues. All have been resolved, and happy to follow up as needed in terms of the documentation thereof.
Appreciate that. I think that would be helpful because I think we're going to get asked about this.
Yep.
It was a high-profile situation. It was publicly reported as it should have been. We talked about it, acknowledged it, and ultimately we need to have a good response to it. If you could also just help me understand, the vibration issue and the decommissioning of the equipment, that is a prospective resolution, right? So that is to confirm that the ongoing issue no longer exists, that we're not adding to the problem. What I'm not clear on, it would just be helpful to better understand either, today, or if you could provide us with information, is confirming that the prior issue isn't a lingering issue. Like the damage that was done by the vibration and by the equipment that created, methane exposure, which is my understanding of the issue, or gas exposure from the landfill. Like this is the issue with landfills. Nothing is perfect, but that is a risk and a challenge to make sure that that is not an issue and that has been confirmed. My assumption is that has been done, but I don't have anything before us, and we haven't been provided information to confirm that. And I think that would be helpful for us if and when we get questions about this issue, because certainly the purpose of this program federally and with us as a local partner is to provide not just affordable but dignified living standards that are safe for our residents. We want to make sure that we can confirm that that is in fact the case. I believe it is.
Yeah.
I don't think that the county would be putting residents in risk, particularly vulnerable residents, many of whom have lingering health issues given their life circumstances. These are, the social determinants of health are very challenging in this population of vulnerable community members in particular. Life expectancy is far lower. The challenges that they face with, health and access to health care is far more challenging. So, it's particularly acutely important here.
Yeah, we will, we'll need to follow up with our colleagues at DEP to provide all the documentation. It's some years ago, and so I just can't rattle it off today, but we will certainly follow up. But I can tell you that with Health and Human Services and DGS, when we identified this site as a possibility, that was the first conversation. Is this a good spot for what is permanent housing versus temporary sheltering, which was previous use? So we will share all of that information as a follow-up item, and we'll make sure that the documentation from DEP is included as well, specifically on the methane, because I think that's really important and obviously a concern for DGS as well as we move forward with the design. So happy to do that.
I appreciate it. And just to reiterate, I have every faith and every confidence that it has happened. I just would like for us to all have the receipts so that we can share it should this be raised, should questions be asked, so that we can speak with confidence and we can share that confidence with the public, because I do think that is an understandable question and concern that will inevitably be raised and that we should be ready to respond to. So thank you.
And the HHS committee is tentatively scheduled to meet on the fiscal year 27 to 32 CIP on March 12th, so we will include that information when we review the project then.
That would be great. Thank you.
Thank you, Councilmember Friedson and Councilmember Lutke.
Thank you, Madam Chair, and thank you, Councilmember Friedson, for raising those issues as the district council member where this is situated and the landfill is situated. I certainly also appreciate being able to go through the historical background of that and being able to talk with fidelity about where we are now and why this is okay now. And I want to just highlight again that disability, I know we've talked about many of the folks who will end up living in these units have disabilities of varying kinds, and I want to make sure that I lift up that those disabilities are not always just physical, and that we are in fact also talking about behavioral health conditions that may coexist even with physical disabilities or other acute healthcare needs. To Councilmember Friedson's point, this is not always a population that has had very good preventive medical care, right? And to our chair's work on health disparities, again, not everyone has had access to the type of preventive medical care that would keep them healthy along the way. And so they're starting and coming in at a different phase in life, and we are trying to do our best to make sure we can keep and further their health moving forward. I'm excited about this project. I know that it is a small number in a large need that we have, but I also wanted to lift up the fact that there was the money that was going to go to the non-congregate sheltering, and I know it 100% deserves to go back to this project. But I don't want us to lose sight of the needs for the non-congregate sheltering, particularly in the Up County, and just wanted to give any of you who are seated there some opportunity to talk about that and forward-thinking thoughts on that non-congregate sheltering.
Thank you for that question. And pardon me, I didn't introduce myself. Christine Hong, Chief of Services to End and Prevent Homelessness with the Department of Health and Human Services. So when we were looking at how to utilize this funding, given that we couldn't identify a site, a hotel, for example, that we could, that was cost effective, that we could afford using the funding in addition to rehabilitating the facility, we started to think about what possible uses there were. And the two primary needs at the time, and this is probably 2.5 years ago, were non-congregate shelter, and we were coming out of the pandemic, and that certainly has been a need. It's also been a need given that our safe havens programs were closed except for veterans. And so that is a space where it is not congregate shelter, and it has the supportive service staff on site 24/7. So it's structured very similarly to permanent supportive housing, except that it's not housing, it's more shelter. And one of the things that I think that you have heard me discuss previously is the need for a model of housing or shelter, a model of shelter called behavioral health respite. So this is something we are also pursuing and looking into, and that would help to create a shelter setting that is not congregate, that has the supportive services needed for people with severe behavioral health conditions. And so we are continuing to look at that in partnership with Behavioral Health and Crisis Services. And so it's not that that need doesn't exist. It's also that we have so many people, our goal is always to house people to end their experience of homelessness. And we have so many people who are very vulnerable and who need a model of housing like this, similar to Cordell Place and Seneca Heights run by MCCH, and the Residences at Progress Place run by Interfaith Works. Continuously, if you ever join one of our coordinated entry system calls, which is where we make the referrals to housing, frequently case managers will say this individual is very vulnerable, and they're assessed to be very vulnerable, and they need a Cordell Place or an Interfaith Works Residences. So this is an opportunity for us to move forward and expand the number of placements for the very vulnerable, for the chronically homeless, for people with severe behavioral health conditions. And so we decided to move in that direction. So that sort of sheds light on the discussion, and though both are needed, we are pursuing the other option also for non-congregate shelter for individuals with behavioral health conditions.
Thank you. I just want to thank you for all that you do, and also to thank Greg Ossent for noting that you have a backup plan should any funds be left over after completion of this project, and keeping Seneca Heights in mind for that roof replacement. So thank you for that. I am grateful that we have the funding, and I look forward to supporting this.
All right. Thank you, Councilmember Ludke, and thank you, Councilmember Friedson, for raising those important points. Is there a motion to recommend approval of the supplemental appropriation? Is there a second?
Second.
All right. All those in favor? All right. The motion carries. The committee recommends approval. Nicole, when is the full committee going to do final action for this?
We have not scheduled that date yet.
Okay. All right. We will keep you posted. Thank you, everyone. Oh, welcome. How are you? Did you need All right. Let's have our second item. Good morning. Everyone get situated. All right, so our second item is the OLO report 2025-7, racial disparities in maternal and infant health outcomes in Montgomery County. As I mentioned at the outset, I requested this report in 2022, the same year I joined the council, because the overturning of Roe v. Wade was predicted to have devastating outcomes for women of color and their children. I recognize that this was a crisis requiring immediate attention. If we want to make a difference, we need baseline data and evidence-based solutions. Every day we delay action, we risk losing another mother or child, leaving families to grieve their loss, and resulting in children and families without their mothers and spouses. I will now ask our presenters from the Office of Legislative Oversight to walk us through the report, since it has been some time since we last discussed the topic, and we do have a new committee member. And thank you to Councilmember Mink for joining us. Then we will hear from Department of Health and Human Services staff about their progress since the report and its recommended findings were released. And then we will take questions from colleagues and myself. So without further ado, Ms. Carrizosa and Caliandurg, let's get started.
Good morning. My name is Natalia Carrizosa, and I'm here with my colleague Chitra Caliandurg. We're here from OLO to present the findings of our report on racial disparities in maternal and infant health outcomes. We're going to take about 25 minutes to make a PowerPoint presentation, but before we get started, we want to take a moment to thank all of the individuals in the county government, the state government, the community, and policy experts who provided information and insights for this report. We really appreciate the time that everyone took to speak with us and share their perspectives, information, and data. So the next slide is going to give an outline of our presentation today. I'm going to start with some quick background on the report and on maternal and infant health outcomes in the U.S. Then I'll talk about the drivers of racial disparities in these outcomes. Next, I'll talk about promising approaches for reducing racial disparities in these outcomes from other jurisdictions. And then I'll turn it over to Chitra, who will go over local data on outcomes by race and ethnicity, summarize the local landscape of perinatal services, and describe the county government's maternal and infant health programs. And then finally, Chitra will go over OLO's recommended discussion items for the council. So to start off, some quick background on the purpose of the report and on U.S. maternal and infant health outcomes. The council's request to OLO included 4 components. The first, to describe the causes of racial disparities in maternal and infant health outcomes. The second, to identify communities that have made progress in reducing racial disparities. The third, to present local data on maternal and infant health outcomes. And then the fourth, to assess whether Montgomery County has implemented efforts similar to those in communities that have reduced disparities. Before we dive into those items, I do want to offer some background generally on maternal and infant health outcomes in the United States. The U.S. has the highest maternal mortality rate of any high-income country in the world, and the infant mortality rate is also higher than most other high-income countries. Black and Indigenous mothers and babies experience the most adverse health outcomes. And it's important to note that racial disparities in outcomes are bigger than income disparities. In other words, researchers find that the highest income Black mothers have similar outcomes to the lowest income white mothers. And finally, research suggests that the majority of maternal deaths are preventable. So why do these racial disparities exist? I'm going to talk about some of the drivers. Overall, we find that racial disparities result from 3 drivers. Number 1, the legacy of racist pseudoscientific theories about Black bodies. Number 2, contemporary medical racism. And number 3, structural determinants of health. So this slide describes some highlights from Harriet Washington's book, Medical Apartheid, and it's about the history of racist pseudoscience in the United States. Coming up in the next slide, I'm going to talk about how the legacy of these ideas shows up today. But going back to the 1700s and 1800s, the period before the Civil War, enslaved Black Americans in the southern United States bore the brunt of disease and of primitive and harmful medical treatments. Slaveholders commonly accused enslaved people of feigning illness to avoid work, so some physicians advocated for medical violence to shock them out of their quote-unquote performances. And in addition, physicians purchased or hired enslaved people for conducting experiments that were often violent and brutal. Physicians and medical schools then used their purported expertise with the bodies of enslaved Black Americans to develop pseudoscientific arguments about biological differences between Black and white bodies. For example, they argued that Black bodies did not experience pain and could better tolerate hot weather and tropical diseases than white bodies, and that Black people were inherently hypersexual, dishonest, lazy, and cognitively inferior. These claims were used to justify chattel slavery, sexual violence and exploitation, and medical violence towards Black Americans. Moving to the first half of the 20th century, the eugenics movement demonized Black sexuality and reproduction as roots of social dysfunction. Eugenics refers to a pseudoscientific movement that asserted that social ills can be eliminated by stopping people with quote-unquote bad genetic profiles from reproducing. And in her book, Harriet Washington describes how, quote, in a refinement of earlier scientific racism, eugenics was appropriated to label Black women as sexually indiscriminate and as bad mothers who were constrained by biology to give birth to defective children. Eugenics theories form the basis for forced sterilization laws and targeting of contraception to Black communities. And then finally, in the 1980s and 1990s, the media distorted findings from preliminary studies about cocaine use in pregnancy. They published articles featuring almost exclusively Black families, creating the myth of the quote-unquote crack baby. A 1989 Washington Post column echoed the eugenicist racist theories, stating, quote, the inner city crack epidemic is now giving birth to the newest horror, a bio-underclass, a generation of physically damaged cocaine babies whose biological inferiority is stamped at birth. This myth led to the criminalization of pregnancy, which forced disproportionately Black women to give birth while shackled to their hospital beds. Today, research indicates Black pregnant patients continue to be more likely to receive drug testing during labor and delivery than white pregnant patients, yet studies have found no significant difference by race or ethnicity in the percentages of pregnant people who use illicit drugs. Moving to the present, unfortunately, stereotypes developed over the last 3 centuries have been extremely persistent. This slide summarizes findings from a couple of studies from the last 2 years that describe stereotypes and mistreatment experienced by Black birthing people in the United States. In a qualitative study based on structured interviews, Black women reported that their providers treated them as though they were uneducated, unintelligent, or uninformed, negligent mothers, intolerant to pain, and dramatic or unreasonably anxious. These stereotypes closely echo the racist pseudoscience about Black bodies developed by 18th and 19th century physicians. A separate study recently found that Black, Latinx, multiracial patients experience mistreatment by medical professionals at higher rates than white patients. And mistreatment can include verbal abuse, delays or denial of care, explicitly discriminatory comments, and coercion. In addition to bias among healthcare providers, we identified 3 other elements of contemporary medical racism. The first is medical education and guidelines that improperly treat race as biological. The second is barriers to healthcare access that disproportionately impact Black, Indigenous, and other people of color. And the third is workforce disparities that prevent access to racially concordant care. The report has more information on these items, but I did want to expand a bit on the last one on the workforce. Racially concordant care, meaning care from providers whose race or ethnicity matches that of the patient, can improve health outcomes for Black, Latinx, and Asian patients. But in the perinatal care workforce specifically, studies have found that Black and Latinx individuals are underrepresented in obstetrics and gynecology residencies, And furthermore, the midwifery workforce in the U.S. is 85% white. Unfortunately, this is in large part due to historical efforts and current inequities that have disparaged and suppressed the work of Black and Indigenous midwives. The last driver of racial disparities is structural determinants of health. Researchers often highlight racial disparities in the social determinants of health, defined as the conditions in the environments in which people are born, live, learn, work, play, and age. More recently, researchers have emphasized structural determinants of health, in other words, high-level factors such as laws, institutional practices, and social norms that drive the distribution of social determinants of health. Structural determinants of health include structural racism. So I'm now going to shift gears and talk about promising approaches for reducing racial disparities from other jurisdictions. Before I get into the details, I want to offer some caveats and context. First, policy experts recommend a broad approach. In other words, there is no single type of intervention, policy, or program that can eliminate racial disparities. Additionally, most strategies that I'm going to describe are backed by promising evidence, but the research is not definitive. And then finally, in our research, we focused on initiatives implemented at the local level. So with that said, I'm going to go ahead and talk about two buckets of approaches we saw in other jurisdictions. There's more information about other approaches that we won't have time to talk about today in the full report. The first approach is community-based models that integrate health and social care, and this slide summarizes components included in the programs that we looked at. The first is community health workers. Community health workers serve in their own communities and can conduct outreach, health and nutrition education, informal counseling, care coordination, and referrals to health and human services programs. They serve as liaisons between the community and the healthcare system. And home visiting, the second item above, is one of the ways in which community health workers can provide the support. Community leadership and partnerships is the third item. One of the ways we see this is programs that have governing boards that include representatives from the community. And then some of the programs we looked at also incorporate workforce training, including training community members to serve as community health workers. Policy advocacy is another component, meaning a formal group that identifies needed policy changes and advocates for them. And then finally, some programs include community-based doulas. Doulas, as you know, are professionals that provide continuous support during labor and delivery. Community-based doulas are members of the communities where they serve, and they provide similar supports to doulas, but also some additional support services beyond the traditional doula services. This slide provides some information about Cradle Cincinnati, which is an example of one of the community-based models that we looked at. It's an initiative of Cincinnati Children's Hospital Medical Center and UC Health, which is affiliated with the University of Cincinnati. This program aims to reduce infant mortality in Hamilton County, Ohio, and it incorporates a lot of the components described on the previous slide, including community health workers, policy advocacy, hospital data analysis, and community leadership. At the time of writing the report, they had reported significant reductions in infant mortality, including since 2013, that Black infant mortality rate decreased from 16.5 to 9 deaths per 1,000 live births. The other approach I wanted to talk about in terms of promising approaches is racially concordant midwifery care and alternative birth settings. In the United States, most births are attended by obstetricians and occur in hospitals. Researchers do find that midwifery care is comparable or superior to care by an obstetrician for individuals with healthy pregnancies. In addition, alternative birth settings, such as homes and freestanding birth centers, allow flexibility not always available in hospital settings to practice the midwifery model of care. Today, the midwifery workforce, as I mentioned, is disproportionately white. Birth centers are financially difficult to sustain due to low reimbursement rates from insurance, especially from Medicaid. There have recently been efforts to establish birth centers led by Black, Indigenous, and other people of color that offer midwifery care in the U.S. And qualitative research from a Black-owned birth center in Minnesota, which I'll discuss on the next slide, finds that racially concordant midwifery care has enormous benefits for Black birthing people, including providing agency, addressing individual and community trauma. So the birth center that I've just mentioned is the Roots Community Birth Center in North Minneapolis. It's the only Black-owned birth center in Minnesota and is one of few birth centers in the state that welcomes publicly insured patients. 80% were Black or Indigenous. The birth center offers medical visits that are at least 30 minutes long, and patients can receive up to 22 visits before birth. The extended time and number of visits allows them to address patients' chronic conditions, cardiovascular risks, and mental health issues. And during labor and delivery, they emphasize patient autonomy to decline services and allow patients to decide who is present. They have close relationships with 2 hospitals that receive the 10% of patients that require transfers. And birth center staff accompany the patients to the hospital with their medical records to facilitate that transfer and offer support to hospital staff. So I'm now going to go ahead and turn it over to Chitra to talk about local data.
Thank you, Natalia. So how are racial disparities in outcomes reflected locally? The next few slides present maternal and infant health outcomes by race and ethnicity using data compiled from local and state sources like the Montgomery County Office of Health Planning and Epidemiology and the Maryland Vital Statistics Administration. All birth and death data are reported by the individual's county or state residency rather than the location where the event occurred. Before I get into the details, I'd like to first define the metrics presented over the next few slides. Pregnancy-related mortality refers to deaths that occur during pregnancy or within 1 year of pregnancy. This particular measure cannot be reported at the county level because the number of annual deaths is too small to produce reliable rates. Because of this, OLO provides state-level rates in the report, which is what you will see on the next slide. Severe maternal morbidity, or SMM, refers to life-threatening conditions or complications during pregnancy or childbirth, like obstetric hemorrhage or hypertensive disorders. SMM is 70 to 80 times more common than maternal death. Cesarean births are surgical procedures that are generally safe, but place women at higher risk for certain complications like infection or blood clots. Preterm birth is defined as birth before 37 weeks of pregnancy. Preterm birth can lead to severe health consequences of for the baby, and it is the leading cause of infant death. Low birth weight is defined as less than 5 pounds 8 ounces at birth. Low birth weight accounts for 20% of all infant deaths nationally. Fetal mortality is the death of a fetus at 20 weeks of gestation or more, and infant mortality is the death of an infant before 1 year of age. This slide shows statewide trends in pregnancy-related mortality rates for white and Black women from 2011 to 2020 using rolling 3-year averages. As shown, the Black mortality rate, which is in the dark pink line, has been consistently higher than the white rate since 2011. In 2018 to 2020, Black women were more than twice as likely to die from pregnancy-related causes at 42 deaths per 100,000 live births, compared to 19.2 for white women. While rates have risen for both groups since 2011, the increase for Black women was 35% compared to 12% for white women. This slide shows racial disparities in SMM at the county level. The chart shows the percentage of delivery hospitalizations with SMM in Montgomery County from 2019 to 2022. The dark pink line shows the rate for Black women, the gray line at the bottom shows the rate for white women, and the blue line in the center shows the overall county rate. SMM rates are rising for both groups, but Black women consistently experience rates 1 to 2 times higher than white women. Black women in Montgomery County also experience the highest rates of other adverse perinatal health outcomes. This slide shows county data by race and ethnicity for 5 key measures. The first is cesarean births. Black women have the highest rate at 42% compared to 33% for white women and 35% countywide. The second is preterm births. Black and Latinx women have the highest rates at 10% of live births. Black babies also are more affected by low birth weight at 10% compared to 6% for white women and 8% countywide. And finally, fetal and infant mortality is highest among Black women and babies, 7.9 and 8.6 per 1,000 live births, compared to 4.3 and 3.2 for white women and 5.4 and 4.9 countywide. Our report also examined racial and ethnic differences in health outcomes by maternal characteristics and behaviors. Research finds that efforts that target these individual level factors do not eliminate racial disparities. For example, efforts to reduce poor maternal outcomes have historically targeted teen births, since teens face higher risks than women in their 20s. These efforts have been successful nationally and locally. However, studies show that Black teens have better birth outcomes than Black women in their early 20s, supporting the hypothesis of weathering, which is the idea that prolonged exposure to racial injustice harms Black women's health over time. Additionally, while research finds education lowers maternal mortality overall, it doesn't offer Black women the same protection as it does for white and Latinx women. Data show that college-educated Black women have higher maternal mortality rates than white and Latinx women with less than a high school education. Finally, Maryland data show that even with early prenatal care, Black women are 3 times more likely to die from pregnancy-related causes than white women. So these findings underscore that racial disparities in maternal outcomes are driven by structural inequities, not individual behaviors. Next, I'm going to discuss the perinatal services available in the county. This slide gives an overview of the landscape of perinatal providers, facilities, and programs in Montgomery County. OLO found that most maternal health care providers in the county are OBGYNs. By comparison, there is a limited presence of midwives and doulas. The county has 5 hospitals that offer labor and delivery services, and most births in the county occur in these hospitals. There are also 2 community health services in the county that offer prenatal care, and there are no freestanding birth centers in the county or in the state of Maryland. While midwife-attended births are increasing nationally, the number remains quite small here in the county. This table shows the percentage of county births by type of birth attendant between 2016 and 2023, broken out by the mother's race and ethnicity. As you can see, most births across all racial and ethnic groups are attended by OBGYN physicians. However, the data also reveal a notable difference in midwife utilization by race and ethnicity. White mothers in the county use midwives at over twice the rate of other groups. Our report also discusses 3 of the county's maternal and infant health home visiting programs, 2 of which specifically serve Black pregnant women and their families. The first program is the Montgomery Perinatal Program, or MPP, which is administered by DHHS. MPP is the largest of the county's maternal health programs. It has the biggest budget, and it serves about 1,600 clients each year. Historically, most participants have been Latinx, reflecting the program's original focus. Before 2024, MPP, which was then called Maternity Partnership Program, provided health care to uninsured pregnant women, a group that in Montgomery County was largely Latinx women who had immigrated to the U.S. In 2023, the Healthy Babies Equity Act expanded Medicaid to all pregnant people in Maryland, leading DHHS to transition the program into the Montgomery Perinatal Program. The next program is Babies Born Healthy, or BBH, which is also administered by DHHS. BBH focuses on Black Medicaid recipients living in 7 zip codes in the county where the risk for adverse pregnancy outcomes is highest. BBH is the smallest of the county's programs, serving 185 individuals in FY24, and DHHS reports that there is often a waiting list to enroll. Start More Infants Living Equally, or SMILE, is operated by the African American Health Program. In FY24, SMILE served 254 clients. Unlike BBH, SMILE is open to Black women of all income levels. Data from both BBH and SMILE show that many participants are women who have immigrated to the U.S. All three of these programs provide home visitation and case management services by community health workers, and in the case of SMILE, by registered nurses. While data show Black mothers and infants in the county disproportionately experience adverse health outcomes, the two county programs aimed at this population have significantly smaller capacities and face high demand. While the county's programs effectively reach Latinx mothers with low incomes, Black mothers are underserved relative to their needs. OLO compared select birth outcomes from these three programs with similar county-wide outcomes for Black and Latinx mothers. We found that outcomes vary across programs. MPP and BBH showed higher preterm birth and low birth weight rates than comparable county rates, while SMILE showed similar or lower rates. Cesarean birth rates for MPP were lower than county rates for Black women, but similar to rates for Latinx women. BBH had lower cesarean rates than rates for Black women, but higher than rates for Latinx women. And compared to county rates for Black women, MPP participants had lower SMM rates, while BBH participants had higher rates. It's important to note here that because participants are selected based on high risk factors, their outcomes may reflect those risks rather than the program's impact. Without a more rigorous evaluation, it's difficult to determine how much of the difference is due to the program itself. We also found that the county's programs include many of the elements similar to the programs that show promise in reducing racial disparities in outcomes that Natalia talked about earlier. For example, SMILE includes community representation on its executive leadership committee. All three programs partner with hospitals and other organizations to receive referrals. All three programs offer racially and culturally concordant home visiting services by community health workers or registered nurses. And community health workers go through a 6-month training process. We also found opportunities where county programs might better align with promising initiatives. For example, by implementing governance structures for MPP and BBH that include community members, by establishing formal groups that discuss and advocate for policy changes, by receiving maternal and health infant outcome data from local hospitals, by leveraging Medicaid to fund community health workers, with the caveat that Maryland Medicaid has limitations that make this difficult, and by offering doula services. Finally, our report offers the County Council 4 discussion issues based on the findings that we just presented. First, because program outcomes vary across the 3 county maternal and infant health programs, it may be useful to discuss what can be learned from program outcomes and what additional data are needed to inform future programming decisions. Second, considering that Montgomery Perinatal Program is the largest of the county's 3 programs and now accepts Medicaid enrollees, how could it more effectively support Black birthing people? Third, are there opportunities to add additional elements present in other promising initiatives to the county's existing maternal health programs? And finally, could the county work collaboratively with county and BIPOC community stakeholders, including birth workers and healthcare providers, to expand access to racially concordant midwifery services? Thank you. That concludes our presentation, and we will turn it back to the chair for any questions.
Thank you, Natalia and Chitra. I wanted to give the Department of Health and Human Services a chance to present. And I just want to thank Natalia and Chitra. Almost a year ago, this report was completed. I just want to thank you for all of your work on getting this report done. We know that Black mothers and infants in our county are facing significant challenges. I knew this before I ever saw data, that Black mothers and babies in our county were not okay. And as a Black woman, the experience of navigating these systems is particularly challenging. These systems were not designed with us in mind. Something that is completely unfortunate. But I look forward to hearing from HHS. I know that we have made significant advancements since this report was released. And so,
all right, I think we're just getting
yes, take your time.
the slides shared so Councilmember Luedtke can see them on Zoom.
All right. And if you want
and
to introduce
sure.
yourselves, please.
Yes, Dr. Nina Ashford. I'm the Chief of Public Health Services for Montgomery County Department of Health and Human Services. The maternal and child health portfolio for the county sits under my leadership.
Good morning. I'm Dr. Keisha Davis. I am the County Health Officer.
Okay, so first, thank you for convening this session. Chair Sales, also welcome Councilmember Friedson to the HHS Committee, and thank you for attending, Councilmember Ming. And always good to see you, Councilmember Luedtke. So we wanted to provide a brief update as our OLO colleagues shared. Much of this data is FY24. We are now rounding out FY26. So we did want to take an opportunity to provide some programmatic updates in terms of where we are and talk a little bit about the nuance in some of the programs. So this first slide does a comparison between the three programs that are highlighted in the OLO report. And there's a couple of important notes that I wanted to make sure to highlight because they drive some of the things that we see. First, when we look at MPP, BBH, and SMILE, as a reminder, BBH and SMILE are two programs that specifically target Black moms. MPP is general fund funded. SMILE is general fund funded. BBH is reliant on state grants. So just inherent in its funding structure, if grants get cut, which has happened, and we have a request in for the next budget cycle to make that whole. Obviously, depending upon what the county executive's budget is, that places just an inherent challenge in terms of resources for BBH. You can see here the difference in terms of funding amounts for the programs with, as was noted in the OLO report, MPP receiving the largest proportion of the funding. When we look at the number of FY25 clients, MPP saw about 1,500, with BBH seeing 195 and SMILE seeing 144. Now, one thing I just want to reiterate is that MPP has historically served Latinx moms. A lot of this is a byproduct of policy decisions as far as health insurance coverage in the state. So because MPP targeted moms that were uninsured, we actually paid for prenatal care. We had partnerships with the hospitals. Many of the Medicaid moms in the county were eligible for Medicaid, so they didn't necessarily need MPP in terms of one of the biggest incentives being that coverage of prenatal care. When Healthy Babies Equity Act passed, we started to actually see the shift. Just as it's a great natural experiment of how policy actually trickles down to real life services and impacts. So we saw that before the Healthy Babies Equity Act, about 90% of the clients were Latinx. After Healthy Babies Equity Act, about 80% of the clients were Latinx. So we started to see a larger increase in the number of Black moms that were served by MPP because it was now everybody had Medicaid coverage, and it was more of a program of offering those home visitation services, not just access to prenatal care because you didn't have insurance to get it through your doctor. An important point to note is that for both MPP and BBH, the eligible population are uninsured clients. Again, most moms are now insured because of Healthy Baby Equities Act. and Medicaid, so moms with Medicaid. Smile, on the other hand, actually serves women regardless of their insurance type and status. And so this is a really important synergy, especially for our Black moms. We saw with the data with the OLO report that actually being higher income, higher educated, they have worse health outcomes than our teen moms because of the weathering hypothesis. We're seeing that to be true, but those moms would not be eligible for BBH under our current eligibility criteria, which is driven by the grant requirements that it specifically focus on Medicaid moms. So SMILE is actually a really important partner, and BBH and SMILE work closely together where they can serve moms regardless of their income, regardless of their health insurance. So if we have a higher income Black mom that might have private insurance, they can still be served, but we refer them to SMILE. Also to note, SMILE tends to serve up county residents. BBH tends to serve down county residents, but the programs will go back and forth depending on capacity. The programs work very closely every month to understand, do you have space to take on additional moms? Who's at capacity in terms of their caseloads, et cetera. Next slide. So this slide looks at the number of clients that are actually served by the various home visiting programs. This first table looks from FY21 through FY25, and you can see relatively stable numbers across BBH, SMILE, and MPP. Now, one of the questions that we've been asking over the past, since I've been here, 2 years tomorrow, is that are we reaching the eligible population? So of the pregnant childbearing women in Montgomery County that might be eligible for our programs, who are we not getting to? Right? So that is what this second table is attempting to estimate. This used data from the small area health insurance estimates. And then we laid over that Census American Community Survey data for race and ethnicity breakdown, and also took the fertility rate for Montgomery County. So this looks at, based off of the numbers that we served in this first table and the potential denominator of women that would be eligible for our programs using these different estimations, how many are we actually serving? So overall, based off of these estimates, we're serving about 60% of the moms that would be eligible in Montgomery County with our services. When we look at non-Hispanic Black moms, we're serving about 37% of the non-Hispanic Black moms, about 64% of the Hispanic moms, 31% of the non-Hispanic white moms, and 15.9% of the non-Hispanic Asian moms. And these percentages relatively mirror what we see in terms of Medicaid as far as Medicaid coverage. But I think the important note and takeaway here is that if the goal, with the resources that we saw on the previous slide, with the numbers that we're seeing in this slide, if the goal is to try and reach 100%, which we all know you should never make a goal of 100%, but let's say 80% of the eligible moms in each racial and ethnic group, that's not possible with the current resources that we have available. It's also important to note that there are many moms we reach out to across all racial and ethnic groups that are not interested in the services. Our teams make multiple contacts. They're lost to follow up. We work closely with our partners in OESS for Child Protective Services. Sometimes, we are able to find and locate moms that way. So there's a lot of different factors why a mom might not be reachable, interested in services. And sometimes they're not interested in having a nurse or a community health worker come to their house, especially in this current environment. That is one of the things we're seeing, particularly for our Latina moms. They are very concerned about ICE and immigration enforcement and having someone come to their home and possibly being followed by an ICE agent, et cetera. Also thinking about our services being offered at a time that is actually, if mom is working during the day, right, that means we need to schedule our home visits for evenings or weekends. And so being creative about our staffing and flexible in our staffing so that we can actually meet moms where they are. Next slide. So this looks at it's an updated table of the one from the OLO report, but it looks at the MCH home visiting program birth outcomes for FY25. A couple of points to orient folks to this table. So for MPP, the comparator, which is in orange that we used, is the Latinx Medicaid population. If there was no data available for Latinx population, we used the overall Montgomery County population. For BBH and SMILE, we used the Black Medicaid population as the comparator. And again, if there wasn't data available for the metric, we used the overall. If Medicaid was not available, we used overall. So what you can see here is that BBH shows lower preterm and low birth weight rates than the Medicaid benchmarks. MPP outcomes are higher than Medicaid benchmarks. I think it is important to note that there has not been rigorous statistical analysis done. It's just a crude comparison of rates. So I would not say that these differences are statistically significant. We don't have p-values, things of that nature. And I think it also reflects that these programs are seeing, reflecting a higher acuity clients than what we probably see in Medicaid overall. What we also see is that the C-section rates in the county programs remain below or comparable to Medicaid norms. So again, this is just an opportunity, a snapshot to see how are the outcomes, some of the key outcomes within our maternal and child health programs comparing to what we see in the broader Medicaid populations. And I believe that was my last slide. So I will turn it over for any questions.
Thank you. If we can just put the first slide back on the screen with the programs that are currently available in the county. Thank you all again for the updates. The report confirms that Black women in our county are not receiving the services, and the outcomes and access are glaringly clear. Our system is not adequately structured to address these inequities, despite being one of the healthiest counties in the nation. We like to tout that unique distinction. But a Black infant in our county is over twice as likely to die in infancy compared to a white infant. Additionally, Black women face a 42% chance of cesarean delivery compared to 33% for white women. Current strategies, including expanding access to health care, reducing teen births, promoting early prenatal care, have not effectively closed the racial gap, while other communities have achieved notable success. For example, in the report, Baltimore cut its infant mortality rate nearly in half. That's from the OLO report on page 69. Cincinnati cut its Black infant mortality rate from 16.5 to 9 per thousand. These are real programs with real outcomes, and I want to understand why we're not learning from them. The county has programs, as you've mentioned, that are doing good work, but looking at the amount of money that we're spending and one program from general funds that are going to a population that doesn't have the disparities and outcomes that Black women and babies have is concerning and alarming. This isn't new data. I believe this is this 2025 data or is, okay. The MPP, Babies Born Healthy, and SMILE program, I don't want to discount the good work that is happening and the homes that they are reaching, but the Black birthing individuals are not getting the care that they deserve. And so I'm glad that we have some baseline information to now look at some of the enrollment barriers, resource constraints, because now we can actually develop some tangible solutions. I do not want to ignore, underestimate the federal impact that these cuts have had on maternal health programs. The CDC's reproductive health division has been gutted. And so it's on us, the local level, to make better decisions and ensure that our Black, Indigenous, and people of color populations, which are growing the fastest in our county, have the resources they need. If we don't take action now, no one else will. And so I want to ask some questions before I turn things over to my colleagues. We see the programs that have been underway. What steps has the Department of Health and Human Services taken since the report's publication to address the racial disparities in maternal and infant outcomes? If you can provide updates on the Community Advisory Board status, funding amounts allocated or reallocated to address the disparities, any additional investments that are not included on this chart, any new partnerships that have been established since the maternal summit that was hosted last year, outreach efforts that have been conducted, seeing these significant disparities between the populations reached and the targeted populations in need, any doula companies that have been contacted, workforce development plans for doulas, any new healthcare providers recruited and placed. And I can repeat any of those if needed.
Okay, I was trying to take notes on your question,
Okay.
so if there's something I missed,
1, 2,
definitely
3,
let me
4,
know.
5, 6, 7, 8. That's 8. Okay.
Okay, can you, sorry.
Yep.
I think,
Community
can you-
Advisory Board status.
Okay.
Any funding amounts allocated or reallocated to address the disparities to treat the targeted population. Total investments, unless it's all encompassed in this slide. New partnerships that have been established since the summit last year, the Maternal Health Summit. Outreach efforts conducted. Number of doula companies contacted. Workforce development plans for doulas and midwifery programs. New healthcare providers recruited and placed.
Okay, thank you for repeating that.
Of course.
So one thing I will note, within our maternal and child health program, we do have our community action team, which part of what they do is review all of our fetal and infant. There are fetal and infant maternal mortality and child mortality review board, and that is a cross-sector group of county MCH staff, hospital partners, community members, and for every unfortunate infant maternal, and we haven't had a maternal death recently, and child death, part of what they do is look for where were there opportunities within the county programs and where do we need to refine county protocols to strengthen the maternal and child health home visiting programs. So we do have the community action team that has been in place for some time, and all of those recommendations go directly to MPP, BBH, and SMILE. And there are lots of improvements that are made to those programs based off of recommendations from that group, also to the broader healthcare community as well. So if there are trends and themes that we're seeing, we can share that with our hospital partners. Like I said, we have hospital members on the community action team. So just wanted to highlight that. In terms of the funding amounts, this is all encompassing of the funding amount. So there has not been any reallocation. I will say that BBH did receive in FY25 the McV home visiting grant. Now, I will just note, since we always talk about federal impact and partnership, when we had originally put in this grant, we had put it into focus exclusively on babies born healthy. About 8 months into the grant, we were told from the state, we didn't realize that this was just targeting Black moms. You can't do that. Now, I am going to read between the tea leaves that I think this was probably more of an effect, a chilling effect from federal actions around DEI. I am certain that they read the grant application, but we had to adjust that whole plan. It was going to be exclusively for our BBH moms. We had to open it up and make it broader. So it's now first come, first serve. Again, I think this highlights one of the challenges when you have a program that is funded by grants and folks are, concerned about the federal wins that happen. I will also note that in terms of total investments, and some of the partnerships that we have done, we have actually had a number of different partnerships take place. So we have worked with USIS, the Uniform Services Health University, is actually working. It's a MPH. Many of them are MD, MPH, PhD students working with babies born healthy right now to do a thorough needs assessment. One of the things that we asked them was to look at and help us understand for those moms that we're not reaching, how can we better get access to them? So they have been working with our BBH team. They're putting together a full needs assessment for us to be able to do that work. One of the things that I noted when I came into this role is the incongruence in terms of the curriculum that is being used between the two programs. And so when I look at the outcomes and I put on my program evaluator hat, my question is, are these outcome differences we're seeing what is it due to? Is it due to that we're not implementing the intervention with fidelity? Is it that the intervention is not evidence-based? Is it something else? And so one of the things that we did was we had a preventive medicine USIS resident actually do a full analysis of the curriculum between MPP, which has been using protocols that were developed over the past 30 years, BBH, which has based most of their curriculum on the March of Dimes curriculum, and SMILE, and then MeHow, which is the new evidence-based model that we are using through the MIC-V grant. Now, just a quick segue, when we talk about evidence-based models for maternal and child health visiting, there are a number of evidence-based models like nurse-family partnerships, MeHow. Two of those models are actually reimbursable through Medicaid. MeHow is not, and that model was chosen because it gives us the most flexibility in terms of using community health workers and nurses, which is what our teams are currently comprised of. If we switch to, for example, nurse-family partnerships, where registered nurses, not LPNs, but registered nurses are the main deliverer of care, it would have much bigger implications on our staffing structure. The community health workers would basically no longer have a place in the work. But I just wanted to just make that quick caveat. So we're now switching to the MeHow model, which, for an example of some of those differences, in our current home visiting protocols, they visit once per trimester. MeHow requires monthly visits to families. It is a standardized curriculum. It is a standardized education, and it is being evaluated by Vanderbilt University. So the entire Babies Born Healthy team actually went to Tennessee to do the training on how to implement MeHow before the state said we couldn't do it. That entire team is trained now. Great use of resources. I'll put that there. But what the overall plan is, and how we're trying to make lemonade out of lemons, is with this pilot, we will be able to test out the kinks of what it's like to implement MeHow within our programs, with the overall goal being to transition our entire MCH program to MeHow. So regardless of if you're an MPP, BBH, or SMILE, everybody's foundational curriculum will be this MeHow model, but then we will retain the culturally relevant programming, education, and tracks through BBH, SMILE, and MPP, ensuring racial congruence with a nurse or a community health worker for the mom, but it will allow an actual evidence-based curriculum and standardization across all moms, and ensuring that even if a Black mom is an MPP, she can still get the BBH programming, the events, the right from the start, all of those things. So that is just one example of what we have been doing to really look at and realign the curriculum. I have also asked the team to look at our screening tools and triage tools, because one of the things that will screen you as high risk is being a first-time mom. For anybody that's been a first-time mom, I'm sure we would all say it's high risk. Is that truly high risk in the sense of having to apply limited resources? Probably not. Our high risk should probably focus on, exactly. Age, chronic condition diagnosis, and SDOH need. So how do we make sure we're targeting our limited resources to actually reach the moms that are highest at risk? So that is another thing that we have been doing to try and revamp the curriculum. We have not made, I'm just going to be candid, we have not made any outreach to doula companies because we don't have any money to pay for doulas for our clients. So, Maryland has just started covering doulas in Medicaid. I will say that my understanding is uptake of doulas actually enrolling to deliver those services has been relatively low. Just because you build a benefit doesn't mean that providers are going to be there to deliver it, and the reimbursement rate is lower than what you would pay in, if you were just a private person. So I think if we had resources to give each of our moms a doula, would love to do that, but we don't have that opportunity right now. And same for midwifery. Ultimately, since now most of our moms do have insurance, they are able to select their OB provider. Our teams do education around some of the early, not just importance of entrance into early prenatal care, but also, think about a midwife. But as you saw from the OLO report, midwives are few and far between compared to the OBs. So that is an important thing to note as well. I am looking at your list, Councilmember Sales.
Workforce
Okay, you want to talk
development
about more about the partnerships?
Any outreach efforts conducted? I mean, when I see these numbers and I see 1,600 people have been contacted or have taken advantage of this program, that means they're getting regular home visits. I'm just wondering how we are deploying our community health workers to reach more people, because everyone has to be recertified in Montgomery County to take advantage of Medicaid. So we know who's getting Medicaid, and we should be aware of who's pregnant, what their demographics are. So what outreach are we doing once they are approved for Medicaid? How are we reaching out to those mothers to make sure that they are getting the home visits and enrolling? Are we leaving residents to contact us to take advantage of these programs? Okay,
No.
so if you could tell me more about our outreach efforts.
Yes. So any mom that becomes eligible for Medicaid based off of pregnancy, we actually get a list from the state, and our administrative care coordination unit and our perinatal care coordination unit, our PACT and ACCU teams, actually call every single mom that is newly eligible and screen them for services. And then they refer them either to MPP or BBH. So every mom that is newly enrolled in Medicaid gets a contact by the administrative part of our MCH team to reach them. With that said, a big gap that we're trying to figure out right now is if mom already had Medicaid, let's say she had Medicaid for 5 years and got pregnant, we are really struggling to figure out who those people are. We are working to try to get access to CRISP to see if that can help with some of that integration. It has been incredibly challenging to be able to do that, but that is a gap. I will also note that we get referrals from the infants at risk from the pediatrician's office. Now all of the hospitals in Maryland are required to fill out the Maryland perinatal infant at risk assessment. Those come to us. We get referrals directly from OB offices and other programs. So our team is doing a bulk of the outreach. And I will just note, we were actually pretty worried after Healthy Babies Equity Act that we wouldn't have any moms to serve because we didn't provide prenatal care anymore. But we've been able to maintain the same number of women served because of all of the outreach that our team is doing to these moms. So to answer that question, and then I'll let Dr. Davis continue on with outreach.
Thanks, Dr. Ashford. Just to talk a little bit about some of the outreach efforts that we've had. So since we had the convening last year, we've been working to kind of convene the group of stakeholders who are interested in this, and worked with a couple of organizations who applied for funding through the Greater Washington Community Foundation's partnership with Care First. There were 2 awardees in our area, National Center for Children and Families, as well as She Rises, who are both going to be working on Black motherhood. So National Center for Children and Families is working on a Black motherhood project, and She Rises is also working on support for Black moms. The proposal, unfortunately, that was not funded was one to provide more administrative support for the coordination that would happen amongst the different groups in the county. So we, within the county, are working to develop that network and base of support, but there is not additional funding to do it. And so we are trying to do that using existing resources in partnership with what we have, working within the structure that we have. Both of those projects, She Rises and the Black Motherhood Project with NCCF, are just now kicking off in terms of their funding. So we have meetings scheduled with them over the next couple of weeks to, one, work on, give them the information that we have to help identify need in the community, to try and work to extend services and not duplicate services. So to identify where the gaps are and make sure that we are filling the gaps, and then, really making sure that we are coordinating amongst the programs that are going to be in the community so that moms feel supported and not kind of pulled apart from the different resources. I will just highlight the event that we did have last year that brought together hospitals, community providers, and persons with lived experience to talk about Black maternal health. And we'll highlight our hospital partners. Each of our birthing hospitals had the opportunity to present on what they were doing. They are an important part of the conversation. Each of them, I was actually very much reassured by their presentations. Each of them has a plan in place to address Black maternal health that is multifactorial, from implicit bias training to running drills to coordination with moms before and after delivery. And I think it's important, as we have these conversations, that we are thinking about people are multifaceted, and the inputs that we need to address maternal health disparities also need to be multifaceted. There is not, as much as we would like to have kind of the one-stop shop answer, it is very much a combination of all of the different things to help address the issue.
Okay, and the Community Advisory Board status.
Yes, so that was what I had mentioned about the community action team that meets every month, and recommendations from the fetal and infant mortality review boards and child mortality review boards. Part of that work is assessing what were the connections with MPP, BBH, SMILE. Was there any dropped balls or lessons learned that need to be fed up back up into the program? The programs actually changed how they were intaking and triaging clients based off of referrals from FEMA CAT. So that, I would say, that advisory team exists. Now, there can definitely be a broader conversation about whether or not it would be a good use to have another advisory group that is specifically focused more on the programmatic side. Because the CAT team really does think kind of system wide, not just on MPP, BBH, and SMILE, but that does exist.
Okay, I just want to make sure that their charge, in addition to overseeing these programs, is about eliminating these disparities in maternal health, and to hear what their regular recommendations are. And then my last question before I turn it over to colleagues. I understand that there was a birthing center here in Montgomery County, and there was a discussion about opening a new one. Can you share, are there any findings about why the previous one was closed? What efforts or advocacy has happened? We are about to review the county executives make final decisions on the capital improvement program soon. And given that this program, this report's over a year old, these statistics aren't getting any better. You're coming up on your 2-year anniversary. What communications have we had or discussions with the county executive on these disparities and plans for improvement, increased investments, and other needs related to these issues?
Yeah, so we did put forth as our Babies Born Healthy grants were cut this year. And so we did put forward a funding request to make those whole moving forward. I will also note that in terms of the birthing center, so there was a birthing center, I believe it closed about 13 years ago. My understanding from the midwife who worked there was that it just was a financially insolvent model. They weren't able to keep their doors open. I'll be completely honest, I think that if we wanted to get a new birthing center open, obviously would welcome that. I don't know if the ROI is still there from a financial perspective, and if there are any midwives or providers that would be willing to take that financial risk. And the question is the county want to be in the business of kind of subsidy in perpetuity to keep that center open, given all of the financial constraints? I would obviously love that. But I also know that there's lots of competing fiscal priorities as well. I think if one of the things that just in thinking about a future where we have a birthing center is, are there any regulations in place that make that prohibitive? So when I was in Boston and they were, fighting for a birthing center, there was lots of arcane regulations that required the birthing center to have an ambulance bay, and all of the providers had to have admitting privileges at the local hospitals. Are there regulations or policies in place that would make the operation of a birthing center unnecessarily more complicated that the county council could address, so that if there is a group that is willing to kind of jump in and say, hey, let's rebuild a birth center, I think there would be a lot of momentum behind it. But we need to make that as easy as possible from a regulatory perspective, but also it is that much broader conversation around the ROI and health insurance and all of that as well.
Thank you, Dr. Ashford and Dr. Davis. I look forward to looking at some of the other models and how they're being funded in other states. And I will turn it over to Councilmember Luedtke first this time, then Councilmember Friedson, and then we'll hear from Councilmember Meek.
Chair, can I please add a comment?
Oh, sure.
I
Yes,
just
go
wanted to
ahead.
share that I've just been doing some research with the Office of Healthcare Quality, and so a recent report showed that there are 0 birthing centers in the state of Maryland. Through COMAR last year, there was actually a change in the language where a birthing center meant a established independent birthing center as we traditionally think. So even like if you Google birthing centers like Adventist, Shady Grove, they're all called birthing centers. But due to the changes in the rule with COMAR, there are none currently existing. So the Office of Healthcare Quality hopes that the updated changes to COMAR will encourage new birthing centers to emerge. But I wanted to just highlight and support everything that Dr. Ashford has said, and stated that if we did it in Montgomery County, we would be
the first. Yeah, yes. I attended the Congressional Black Caucus Conference and sat in with the founders of the birthing center that you mentioned that is underway, I think, in Minnesota. And so, I don't know what their funding model is, but I know that we should look into that. So
We definitely can. Thank you.
thank you. Or was it Michigan?
Good to go?
Yep. Yes.
Okay. I just
Yes.
wanted to double check.
We cannot see you, but we can hear you.
Great. Okay. Well, and thank you, Dr. Ashford.
There you are. Okay.
Hi. Thank you, Dr. Ashford, for going over the complexities of the birthing centers and the licensing and the financial models, because it is a really deeply complex situation. And we have a new father here on our team, HHS, and it's been a hot minute since I've had to go through all this. But there were birthing centers back when I delivered. I did not deliver in one though, because I had what were considered high risk pregnancies based on my age and existing autoimmune disease. Right, so they were treated differently, and I think it's hard to have a discussion about these things and about the high number of cesarean births, period, that happen in the state without acknowledging where the nexus of law and medicine have come into play together, and where because of medical malpractice claims and things, then there had been a shift, particularly around, like I said, when I was having my children between 2007 and 2011, of pushing more cesarean births. And I think that trend has continued. And early on, our folks from OLO had referenced that all maternal deaths have increased since 2011, regardless of race. And that's a fact that's just astonishing when you think about modern medicine, period, right? And then we dive down into the different health disparities based on race. But I was wondering if anyone, either Dr. Ashford or Dr. Davis, or our folks from OLO who did the report, can comment on the why. What are the causes that are causing those rates to increase from 2011 to the present?
Hello, this is Natalia Carrizosa. So in our report, I don't believe we have specific information on causes. I know from all the research that we did, one big factor, as I'm sure you know, is maternal age. And if maternal age is increasing, that could contribute to increased mortality rates. But again, this is not a topic we were able to address in detail in the report.
I can answer a little bit, just echoing that from the medical literature. So the unfortunate truth is that part of it is age. In Montgomery County and in Maryland, we have a higher average age of delivery for women. And so with increased age, you see, increased chronic diseases, diabetes, hypertension, and other things that can increase the rate. Also, those things that can increase the chances for having a cesarean section. And so there are a lot of things that factor into why does somebody have a cesarean section. And sometimes in the moment, that feels like the safest thing if the baby or mother is in distress. But we also know that there are longer term complications of having that cesarean section, more likely to have, postpartum death, hemorrhage, all of those complications that we see. And so we know that when somebody is healthiest going into pregnancy, then they are likely to have healthier outcomes afterwards.
No, thank you. Thank you for that. And that was going to be my other question. Like, if I think about the top things that cause some challenges during pregnancy, even if the mother was healthy going in, things like gestational diabetes and preeclampsia and placenta previa, and then I think about, true, right? Like I said, I was in my 30s before I started having children. And that's considered advanced maternal age, and that comes with other things. But wondering again, in terms of studying where we're having our interventions and what common threads we are seeing, then that can inform not just what we're doing in the context of pregnancy, but what we're doing overall for women of different racial backgrounds and different socioeconomic backgrounds to help get at those ongoing conditions that need more preventive medical care. So could you speak to that a little bit about sort of how these programs that are focusing on maternal fetal health also inform our public health approach with respect to overall preventive medical care?
I think one thing to address that is, again, getting to the, healthy pregnancies from the start. And so some of that, I think a lot of that starts even in schools. And so, the conversations that we have at school health, the conversations that we have about reproductive health and healthy living, when you are in your teens and 20s, you're often not thinking about preparing your life for pregnancy, but we do want you to be thinking about preparing your life for being healthy, and those things that make you healthy at that age also make you more likely to have a healthy pregnancy. And so having those conversations, and certainly the conversations about reproductive health and access to birth control, and so that when people are having those pregnancies, they are planned and wanted, and we know that folks tend to have better outcomes.
And then in terms of the screenings that are done for those who, once they're on Medicaid, and you mentioned that that's when you all are able to do your outreach to get to them. Typically, on average, how far along are the women in their pregnancies before that screening occurs?
I would need to get that exact number and get back to you so I can follow up. I will follow up because I don't want to tell you an incorrect number.
That's okay.
Yeah.
That follow-up is always acceptable. And then for the MIHAL program, and you were explaining that, I love the use of the community health workers, and I think that's a very good thing. And I do think that only visiting once a trimester is not sufficient, right? And then just wondered whether there was a way to combine the MIHAL model with the reimbursable model. So like, is there something that we can do where we are still using the community health workers, but also able to recoup some of the funds through reimbursable means?
Yes, and I think Councilmember Ludke, I am always looking for ways to bill for services that we provide. I think the reality of the situation is that if we did a reimbursable model, and Maryland Medicaid only recognizes 2, we're going to significantly cut the number of women that we're able to see, because right now it's about our home visiting team, it's like 50% nurses, 50% community health workers, and not all of the nurses are RNs. Some of them are LPNs, and the 2 reimbursable models require you to be an RN. So, there is potentially a world where we could say, hey, for all of our RNs, you're going to do nurse family partnerships, and that is going to be the reimbursable and we'll recoup revenue for that. Everybody else is going to do MIHAL. Now that becomes administratively, as I'm sure, complex, and we're now bifurcating 2 separate curriculum again. There is, we can definitely get innovative around, well, if all of the nurses are delivering nurse family partnerships, what are the things that our community health workers could do around support, education, things of that nature. So we can certainly look into it. Even with the MIHAL model, going from once a trimester visits, which I agree is not enough, was one of the things that alarmed me the most when I came in and really started digging in. We are going to see fewer clients. But as I have told my team, if we see 300 fewer clients a year, but those outcomes on that last slide are now green because they're better than Medicaid, that is worth it. I don't always think quantity is better than quality if we're not getting good outcomes. And I'm not saying this to blame our MPP teams or our maternal child health teams. They work very hard, but there is a balance between trying to serve everybody we possibly can and then making sure that we're serving the people we're serving well. So
thank you for that. And do you know when the Vanderbilt study is going to be completed?
We just started triaging to that nurse last month. So it's every year. The funding is yearly. So after the first year of implementation, we're kind of working through the kinks as we go. So then as we roll out to the broader MCH program, we'll be able to have worked through those things. I will also note, as I'm sure many of you have heard, we're in the process of implementing a new electronic health record within the department. So we're trying to be mindful of throwing a completely new EHR and a completely new curriculum. We don't want everybody's heads to explode, but building the workflows into the new EHR to be able to accommodate that too.
Great, thank you for that, and thank you, Madam Chair.
Thank you, Councilmember Ludke. Now we will turn things over to Councilmember Friedson, and I do want to be conscious of the time because I know that there are multiple questions to be asked, so if we can be brief with our responses. Thank you.
Thank you very much. First of all, thank you to you for really highlighting this issue, for your commitment to health disparities and taking your work prior to being chair and really leading your way as chair. It really is important that we have this conversation, which is overdue. We have a report that's been out there, and we have challenges that we have to face in a federal landscape, frankly, that has made these challenges more difficult to address, as you noted earlier, with the unfortunate response from the state, which I think we can all just presume that is based on their recognition of federal grant challenges that we now have to navigate. We can blind ourselves to the realities of the data, but the report speaks for itself that, if we are not intentional in the way that we target our responses based on the clear and obvious challenge, then we're not going to solve the problem. And I just think we need to, acknowledge that as we are today and continue to talk about that and to lift it up. I am a new dad, so this is a near and dear issue to my heart. I'm not new to this issue, though. I just did want to note, and I am proud of the fact that, I sponsored the lactation bill, the Right to Nourish bill for all county facilities, specifically because of this issue, because of our large proportion of Black mothers who work in county government that we want to support and help them, not only as workers and not only as important members of our workforce, but as part of our community who need to have healthy opportunities. And I don't think there are enough in the workforce. And we need to be leading with the power of our example in county government. And that is one way that I'm proud we're doing that. And that was also part of the paid parental leave bill that I sponsored, and also the 2022 maternal health panel discussion that we had to really lift up these issues that were really exhaustively gone into by this OLO report in a significant way, which I really appreciate. And that conversation was with the FEMA Community Board and the co-chairs, as well as nonprofit partners, including Aaliyah in Action and some others, and really helped to lift up some of these issues. And we've continued to lift this up through the council's perch, through proclamation and others, to make sure that we're talking about these issues in a significant way, and partnering with community-based organizations, the Deltas, and we have a Delta sister here who do great work here as well, among others that really have focused on these issues. So I just want to acknowledge that. But it has hit close to home now, and I see it in a very real way, and I'll just note, and you noted, that it's now advanced maternal age. I have to be very careful about this. It used to be geriatric pregnancy. We no longer use that term because it's a horrific thing to say to a young mom. So if my wife is watching, advanced maternal age to all those women out there, I still think that's a bad term, fortunately, unfortunately, but it's certainly better than geriatric pregnancy. But the reality is, we have a high cost of living here. We have a highly educated, highly professional community of dual income families, some by choice, some by necessity, many by both of those factors. So naturally, we're going to be in a place where people have families later. And then you add on the college debt and all kinds of other financial challenges where family formation is just happening later everywhere, and particularly in high cost, highly educated, suburban and urban environments like we're in. And so that is, part of the factor that I think we have to understand and kind of change the mindset of how we talk about and how we address pregnancy and pregnancy related matters, because, ultimately the demographic, just by age, is different than it was 20, 30, 40 years ago, because our lifestyle, our society is different and has changed, and also calls for the need for different dynamics of supports at work, supports in community, and otherwise. So I just really appreciate that. We're doing a lot and yet not nearly enough. I mean, this is a really sobering conversation to realize the massive discrepancies that cross every demographic dynamic except one, race. And that is a sobering reality that we have to face on this issue, like so many others. And I just wanted to see if I could hone in the interest of time. There's so many follow-ups, so many questions, so many things that we could be addressing. I know we'll continue to do that, and it heartens me to be part of this committee now, so I appreciate that. You talked about the birthing center, perhaps not being the best return on investment, despite the fact that we would like that and we would love to see more of it. There are none in the state of Maryland, and frankly, the folks that we would need to support a birthing center are few and far between. I mean, you talked about the dearth of doulas and and midwives, particularly those who are representative of the community that we have. And so it'd be challenging, not just financially, but to staff, it sounded like. But if that's not the answer, or at least that's not the answer right now, what is the best ROI? What should we be focusing on? I mean, there's many things that we need to do to address the root causes here. I mean, that this is a root cause problem that requires root cause solutions. But as we dig deeper into the root cause, what are some specific things that we should be doing where we can get the best ROI, where we can focus on this, where we can leverage the assets that we currently have with community-based health supports, hospitals, and others, healthcare professionals, to really hone in and focus in on this issue?
Yes, I love this question, and I will be brief, Chair Sales. So as noted by our OLO colleagues, this is going to take a multi-sector approach. While the financial ROI might not be there for a birth center, I will say that the quality of life ROI certainly is, and it's always hard trying to balance those two. So just want to point that out. I think there are a couple of things that we can do. First, just thinking kind of lowest hanging fruit is restructuring our maternal and child health programs in the ways that I just shared, so that we're using an evidence-based curriculum, that we have standardization and still providing culturally competent care. We are in the process of doing that right now. I'm engaging the entire management team because I want to make sure that the new approach is not just led by me. They're the closest to the work. So I want to make sure that they have input and are committed to the success of it as well. I think we're continuing to work with our hospital partners. A number of our hospital partners are actually, as Dr. Davis mentioned, implementing various different initiatives. An implicit bias training is not going to fix this. It's not going to fix 400 years of systemic racism. I'm not saying that it's not important, but that is not the one solution. One of the things that I think is most impactful is being able to implement the maternal safety bundles, which are basically, there's 8 different evidence-based bundles you could pick from, and it says all patients get treated using this standard protocol, in an attempt to try and remove opportunities for bias out of the equation, because if you show early warning signs, we're immediately sending you to labor and delivery for assessment. So I know some of the hospitals are already implementing those. I think Adventist, MedStar was doing the one on hemorrhage. I would say that is one strategy we could use there. I think, working with our partners at the state to see if there's any information we can feed up to try and increase the number of doulas that are actually participating in Medicaid, and then having more meaningful connections with our clients so that they can use their health insurance benefit to actually get that doula coverage would be helpful. I would love a world, as Councilmember Luedke noted, Maryland has the highest low-risk C-section rates in the country, which is crazy. But when I was having my 2 children, I could not find low-risk C-section rates for any hospital. So I know in other jurisdictions, they have hospitals produce a maternal health report card. Now, the number of maternal deaths are relatively low, so that probably would not be able to be included. But if every hospital had a report card with some of these severe maternal morbidity metrics, looking at things like hemorrhage, what is your low-risk C-section rate, so that moms can actually make informed decisions, that would be helpful as well. So those are just a couple of ideas of things that we can do. Dr. Davis, I don't know if you would add anything.
Just a couple things. The state of Maryland has produced that maternal health dashboard that does sit there. You can look up C-section rates by hospital as well as the other SMM factors. I'll also say, just thinking holistically, and Councilmember Friedson, you mentioned this, when you think about the social determinants of health, the things that help support women during their pregnancy. So, women who've had a child may have already had a child. So thinking about childcare subsidies, maternity leave, ability to breastfeed, all of those things that help make the systemic process of pregnancy easier often help Black women even more. And so sometimes it's beyond, there's the actual kind of birth itself and, midwives and all of that, but there's also the social structure and the system around them that helps to decrease the impact of racism, honestly, and those social determinants that may be impacting those adverse outcomes.
Yeah, just wondering if we can get access to the state dashboard, and perhaps we should be sharing that on our HHS website or some other prominent place, because obviously it's not as accessible as it
Yeah, it's just a year old.
Could be or should be, but I think that would be helpful for us to be sharing and putting out there and helping. I'll just note through our journey, we saw our midwife a lot more than we saw an OBGYN. Saw an OBGYN on a limited basis, and for the few minutes, of actual delivery. But it was really the midwife who guided us through it. We loved our midwife, by the way, but she was pregnant. Her due date was only a week and a half after my wife's due date. The realities of staffing challenges and human beings who have lives and who have their own healthcare and personal needs. So when it came our time, there was a new midwife who had to be imported in from Frederick, who came to start to transition to provide coverage because they didn't know exactly when our midwife was going to have to abruptly leave without a lot of advanced warning, as I have learned the process, which, by the way, the 511, standard is not perfect. I can attest to that as well. But it speaks to the challenge of the lack of human capital that we have and some of the efforts that we need to do in order to build the workforce in this space in particular. So appreciate the responses on that. Look forward to the racial congruence and the evidence-based model and the MeHow model that you talked about, and really moving forward with those efforts, and look forward to being a partner on that. So,
thank you, Councilmember Friedson. Before I turn it over to Councilmember Mink, I just want to be clear about the birthing centers and the benefits and the return on investment, so there's no misunderstanding. Birthing centers do save lives, and there are good outcomes. They are usually 45% of births in the United States, since they are financed by Medicaid. Local governments can see significant direct savings. Moreover, a research study done by Georgetown University shows that for every 10% of births shifted to birthing centers, taxpayers could save approximately $2 billion annually. And so there are more questions that I have, but I'm going to turn it over to Council Member Mink. I just want to ensure that it's on the record that they are a feasible alternative, and we should be looking into how we can get one here. Go ahead.
Thank you, Chair Sales, for your work on this issue, for prompting this OLO report, and for bringing it back so that we can highlight it today. It's always great to see when those excellent OLO reports, when we really get to put them into use and practice and think about how our funding and policy decisions need to be based on that great data. So I really appreciate the opportunity. What to choose? Okay. So the hospitals are implementing the maternal safety bundles, our hospital partners. Are those plans public facing? Yeah, I don't believe so. When we had our maternal health summit last year, they shared in their individual reports, but I don't believe they're public. Is there a way for there to be transparency, or a plan for there to be transparency about the data tied to the outcomes of the interventions that they're doing?
I mean, I think the maternal health dashboard that we have from the state gives us a greater level of clarity. That's only been out for 6 months. So when we had the summit a year ago, we didn't have that level of data and transparency that we have now.
Yeah, I mean, I think that it's a really exciting opportunity to have, again, an opportunity to have these interventions and then be able to have the before and after. And given that different hospitals are implementing different parts of the safety bundles, and being able to have the data to be able to compare that is an exciting opportunity. And I'm so glad that we have the dashboard as well at the same time. Is there any subgroup data disaggregation that's happening in any parts of this to see, like, if there are different parts of our diverse Black community, for example, who are being impacted in different ways? Is that something that you all think could potentially be useful for us?
Yes, it could absolutely be useful. Unfortunately, we're limited in terms of
just having the 6 OMB categories, which is not reflective of race and ethnicity. We actually have done some analyses looking at differences, and I believe this was highlighted in the OLO report, looking at African immigrants versus African Americans. One of the things as part of the overall restructure is being able to collect more granularity on that data. One of the limitations is our current EHR. So we are hopeful to be able to build that out in the new EHR.
Great. And of course, the would that be helpful is hypothetical. So thank you for talking about that. Yeah, I mean, I think this is an area that we see in not just in this conversation, but in so many different conversations. And so figuring out how we can make those adjustments and really have better disaggregation and be tracking those subgroups, I think could be so helpful in so much of our programming and our budget decisions and all of that. So this is a great opportunity to highlight that. And I'll note also that we have some very undercounted Indigenous populations facing really disproportionate outcomes as well. But it's so difficult for them to advocate as a community without those numbers. So the work to kind of revision and reshape how we're doing that is important. I was really struck in the outcomes chart with the C-section outcomes under babies born healthy. I was like, is that a typo? It's so low, the percentage there. Let me just scroll back to that. The chart with the red, yellow, and green on there. The cesarean births for Montgomery County, if it's possible, thank you so much. For Montgomery County, 2012 to 2021 was 34.5. And for our Black Medicaid comparator was 40.7. Under babies born healthy, 4.3% is wild. And I just want to note that, the results of the results of not having to have a C-section, right? There's so many, but you've talked about a lot. It's way better whenever possible. But also what it implies about the care and the experience leading up to that is so significant. Could you talk a little bit about what this number could mean?
Yeah, I mean, I think at the end of the day, it highlights the great work of our Babies Born Healthy team. One of the things that our BBH nurses and community health workers do is when we start with a client, we give them a form that they give to their provider so that our staff can have a good relationship with their OB and go back and forth and share information. I think it reflects, the education and the self-advocacy that is taught within our Babies Born Healthy program. So I think it is reflective of the interventions working. I do think that, just because context is always helpful when you have an overall N of 198, you're automatically going to have fewer, but I think, and that's not to discredit this great outcome, but I think it's just reflective of all of the work that team is doing.
I mean, the percentage is wild. It's a tenfold. You remove that mom from babies born healthy, and she has approximately,
Yes.
a 10 times greater likelihood of ending up with a C-section. I mean, to me, that's reflective of a very good investment in a space that is dramatically underfunded, and budgets are moral documents, et cetera, et cetera. And this we have really and what Councilmember Sales has had laid out for us today is you cannot miss that this is, as it currently stands, an immoral document. And we are working as a county and as a state to get to a place of morality that is then going to be reflected in our outcomes. But looking at where we are now, we are so far from that. Babies born healthy, riding entirely on state grants, the giant gap between the amount of funding that we are putting directly toward the Black birthing population, and then the numbers of folks who are being served, and then the disparate outcomes. None of that is coincidence, obviously. So can you tell us a little bit about if we were to put more funding? I know we don't have a lot of funding, but I think that we must have the conversation to figure out where we're going. If we were to put more funding towards babies born healthy, is that funding that that the program could immediately put to use? What would that look like?
Yes, if we had more resources, we could immediately put that funding to use. We have had staff who we've had to split their time because of loss of grant funding. So now they're 50% BBH, 50%, supporting the Me-How model. We could make those folks 100% BBH and train somebody else to support the Me-How model, for example. We could certainly hire up. One of the things that has come up, and I'm actually working with Chief Martin at potentially implementing a pilot, is that our BBH clients have really intense behavioral health needs, like severe mental illness needs, lots of coordination. We would love to have our own social worker, actually our own social worker that could do navigation to community services, but then our own social worker, licensed health professional that could actually provide mental health support directly to our clients. So that is something that we would potentially look to do as well, which would just help further those outcomes. But the short answer is yes, yes.
And the first item that you mentioned, that there are providers who are, or that there are certain FTEs, I guess, who are positions that are now being split for the Me-How implementation.
Yes.
But the Me-How implementation work that could be done by someone who I'm assuming is easier to find and hire than that. Could you explain that?
Yeah. So remember, the Me-How is what we're using the home visiting grant for. And all of the BBH team was trained on that. It's like a 2-day training in Tennessee.
Yep.
So because the way grants work is that you can only work on the things that the grant pays for. So let's say we have a nurse, right? That was 100% funded by home visiting, and that got cut. Instead of saying, well, nurse, now you're only part-time and you just need to find a part-time job somewhere else, or letting them go entirely, we have tried to retain staff by saying, okay, we can keep you employed, but only 20 of your hours can go to BBH. The other 20 has to go to Me-How. The ultimate goal is to train the entire MCH staff on Me-How when we convert everybody to that model. But yeah, does that answer your question?
Yeah, that's helpful. We're running short on time, aren't we? Okay. All right. Well, I think I want to end on that note, because ultimately I'm really interested in, as my colleagues have raised, what are some of the most immediate advancements that we can make right now? So we have some clear recommendations around both funding and policy as potential next steps to look at, and I look forward to following up on those with my colleagues. Thank you. I yield.
All right, thank you, Councilmember Mink, Councilmember Friedson, Councilmember Lutke. Thank you to our HHS staff as well. I know that we are short on time, so I'm just confirming the perfect. Okay. Just wanted to make sure that we can follow up on today's important conversations. I know most of the team, all of the team from our first item has since left, but myself, the county executive, we sit in on, Councilmember Lutke is now the member of the legislative body for MACO. I'm on the board of directors for the National Association of Counties. Our legislative conference is this weekend, and I'll be attending with the Office of the County Attorney, Sarah Morningstar, who will be joining me in our advocacy meetings with our representatives on the Hill. If we need money, we need to say we need money. And if we're not getting it from the general funds, if we're not reallocating resources, we need to hear from you directly, because you're on the front lines of these programs. You know where the needs need to go, and I need to know where I need to advocate for resources more specifically and more regularly. I don't want to have these committee meetings to have priorities discussed. It should be communicated. It's a budget year. The county executive is going to be putting together his operating budget, and I hope that it reflects the needs of our community. Based on today's discussions, I do want to request the following. On the affordable living quarters, once that is approved, I would like HHS and DGS to provide the committee with a written services plan for the facility. The plan should include the remediation and air quality status raised by Councilmember Friedson, staffing model, who the service providers will be, and how the referral process will work given the pre-existing conditions and severe behavioral health needs this population will rely on. Additionally, this plan should also include a timeline once designs are ready for approval, ongoing operating cost estimates that council staff has already requested. I would also like to see written confirmation that the referral process has been developed with input from people with lived experiences of homelessness, including a written plan for engaging these individuals in alignment with the Interagency Commission on Homelessness's racial equity work group recommendations. Regarding the maternal health disparities report, I am formally requesting that HHS provide this committee with a written action plan addressing the report's findings and recommendations within 60 days, making this a year since the report was released and bringing us to Minority Health Month, where we will be leading a proclamation to raise awareness about this and other disparities we are tackling in our county. Since the persistent inequities, welcome, Mr. Hassan. Since the persistent inequities in Black maternal health outcomes were highlighted by this report, Maryland has required and implemented a maternal health dashboard across all hospitals to track and monitor cesarean vaginal deliveries and associated adverse events. Most recently, they established a new maternal health subcommittee at the state level, further underlying the dire necessities of this issue and how it needs to be addressed specifically. Just so we're clear about my expectations, I need specific actionable steps with timelines, detailed budget estimates, and implementation. Okay, just so we're clear about my expectations, I need specific actionable steps with timelines and detailed budget estimates and budget implications alongside clear metrics for measuring our progress. I'm not interested in summaries of existing programs. I'm focused on measurable goals and the instituted changes. Furthermore, as we prepare for the capital improvement plan review in March, I would also like to know how our capital investments will meet the critical needs outlined in this report. The evaluation should focus on the allocation of housing units for at-risk mothers and reestablishing a birthing center in a jurisdiction with 4 of the most diverse populations to improve the quality of care and overall outcomes for Black women and their babies, in alignment with the legislative requirements outlined in our racial equity and social justice legislation. Are there any questions? All right, and with that, hearing none, thank you. That concludes today's Health and Human Services Committee hearing. Thank you to my staff for preparing me for my inaugural committee session as chair. Thank you to council staff, executive staff, panelists, colleagues, and the millions watching from home. This meeting is adjourned. Thank you.